Good afternoon, Elder Justice Warriors. I am so glad to have you back as we start a new year and come together to discuss complex topics and share information and resources. My name is Nicole Howell. I'm the Executive Director for Empowered Aging, and I am pleased to bring with you an exciting topic today. A few reminders about our program. We are an interactive group here, so feel free to go ahead and type your questions in either the Q&A or the chat. Great way to get started is go ahead right now in the chat and drop your name and what you do and what brought you here today, what you're excited to learn about. That's a great way to connect with speakers and other panelists. We also offer closed captioning, so feel free to enable the captions by selecting the icon on your toolbar. And as always, we do provide ASL interpretation via the Zoom feed. Please feel free to take advantage of those. Also remember, we are back here the third Thursday of every month from 12 to 1. So we will see you back here again in February. As a reminder, the series is brought to you by Kaiser Permanente, the Artstone Foundation, and John Muir Health. Also, a particular thank you to California Department of Social Services, who's our planning partner and who generously provides the closed captioning and the ASL interpretation. Now, today is one of our most exciting sessions. We are joined by Dr. Mosqueda, former Dean of the Keck School of Medicine at USC, an elder abuse expert. And so we are going to keep it short today for the introduction. And with that, I'm going to turn it over to Dr. Mosqueda.
Well, thank you. It's a pleasure to be here. Hello to all of the participants. The plan today, I'll start sharing my screen in a moment with slides, is to talk about elder abuse from a medical perspective. And we're going to do this in chunks. And what we'll do in order to hopefully keep you awake is I'll pause every now and again, and we'll do a little Q&A or conversation as we go along. I know all of you are well grounded in areas related to aging, so this is not Elder Abuse 101. This is a more sophisticated, advanced version, and I hope you'll find it useful. So, and feel free to give feedback, put in questions and comments in the chat. My friend and colleague Nicole has promised to help me out as we go along so that we can try and address your issues. So let me get to it, and we'll get to my slides here. And I'll just check in and make sure that that they can be seen. Nicole, are we good?
Yes, we are good to go.
All right, here we go, everybody. This is me. I work at the Keck School of Medicine at USC. I'm also the director of the National Center on Elder Abuse, where I work with a fantastic team of peoples. What we're going to do today is a quick review of the physiology of aging, just to set the stage. And then I'm going to talk about physical and lab markers of abuse and neglect. And then we're going to start to close it out with a model we've developed called AIM that I find to be a really practical framework. It's interesting. We use it for research purposes, but I've really found as a clinician that it's really helpful for me in my clinical work as well. And a number of APS agencies around the country are using it too. And then we'll have resources too. All of the slides I will make available to the organizers so that you can have them. So when I fly through stuff quickly, don't panic. Just keep your seatbelts fastened, and you'll have that information available to you. And if anybody wants to reach me, I think I didn't put this in the email, but in the slideshow. But my email is my first name, Laura, dot my last name, Mosqueda, at med.usc.edu. So feel free to follow up with me if any needs arise. All right, let's jump into it, everybody, and talk about the physiology of aging. And I bring it up because it can be hard when you talk about these changes of aging to recognize elder abuse. There are these normal and common changes that we'll talk about in a minute. Oftentimes, as we get older, we have other co-occurring illnesses, might be Parkinson's disease or heart disease, etc. There's medication effects. Oh, this person's on a blood thinner. Oh, this person's on a medicine that makes their blood pressure drop. So of course they fall, those sorts of things. And then there's cognitive impairment, an area where I have particular interest and concern, which is the abuse and neglect of people with dementias like Alzheimer's disease. So it can be really hard to recognize abuse. And one of the things I talk about when I'm speaking to physicians in particular is making sure it's on your differential diagnosis, so that when somebody comes in with bruising, that one of the possible causes can be abuse. Because if we never think of it, then it never comes up. So let's talk about some of those normal and common age-related changes in the musculoskeletal system. Our muscle mass goes down, our bone density goes down a little bit. You've all heard of osteoporosis. We can have what's called orthostatic hypotension, which are these drops in our blood pressure that occur when we move from lying to sitting or from sitting to standing. There are functional changes that occur. So for example, changes in our gait or how we walk, neurologic issues like Parkinson's disease, dementia. Our kidney function declines with normal aging and can decline more precipitously with certain illnesses that affect the kidneys like diabetes. Very important, related to how we metabolize medications. Our skin or integument. If you go to medical school, which costs a lot of money and takes a lot of time, you have to come up with fancier words than skin. So we go with integument. Our outer layer, the epidermis, gets thinner. Our capillaries become more fragile. In our sensory system, we can end up with something called presbycusis associated with aging, hearing loss, and a variety of visual impairments like macular degeneration and cataracts. And I bring this up all as a background because now I'm going to really turn to the hardcore stuff of forensic markers of abuse and neglect. And you can begin to now get a feel for why these changes of aging can make it difficult to figure out what's going on. Because almost any time somebody comes in with an injury, you can find a reason other than abuse that it occurred. And it's usually that they're old. Not a very good reason, but we hear it all the time. So of course they have a pressure sore, they're old, or a fracture, or a bruise, or a contracture, they're old. And I think all of us know that sometimes it's related to aging, sometimes it's related to chronic conditions, medication side effects, and sometimes it really is directly or indirectly related to abuse or neglect. And that's why I want to take a minute to talk about a couple of particular markers that I thought might be helpful to this audience. One is pressure ulcers or pressure sores. And you're probably all familiar with the stages 1 through 4. And as it gets to stage 4, you're down to muscle, tendon, or bone. And they always sound horrible, like really horrendous. Oh my gosh, this person has a stage 4 pressure sore. If this person, though, is somebody who's extremely thin, the distance from their outer layer of skin, their epidermis, to their bone might be less than a centimeter. So we want to be careful about not jumping to conclusions, but that we understand the context of a situation. Because I think most of you are familiar with the different stages, and if not, now's a good time to put it in the chat and ask me to review them. I thought I would spend a little bit of time talking about these, what they call unstageable or deep tissue pressure injuries. The unstageable ones are ones that have an eschar or sort of a scab over them. So you really don't know what's going on beneath them. But I'm seeing, I should have mentioned one of my important qualifications to be talking to you is I'm a volunteer long-term care ombudsman. And what I've been noticing in nursing homes is sometimes people have what's called a deep tissue pressure injury. And so we hear these sometimes places saying, well, it was fine yesterday and it just erupted today. Well, that can happen with a deep tissue pressure injury. I'll show you another slide just in a moment about that. But I want you to be careful because these things don't come out of nowhere. Skin wasn't just looking normal and now all of a sudden it erupted. That should really get your antenna waving if somebody said, oh, everything was fine yesterday and now they have this big stage 4 smelly pressure ulcer. So the skin might be intact before it erupts, but what you get with deep tissue pressure injuries, you'll see in these different layers, is there's already a lot of damage that has occurred, even though the skin is still intact. So this is just a close-up of, okay, skin is still intact, but a lot of damage is already being done all the way down to the bone in these deep tissue pressure injuries. So I just want to do a warning because I'm going to show a picture of a deep tissue pressure injury. So you can turn away for a moment if you want. But here is a picture of a deep tissue pressure injury. And you can imagine when this thing erupts, the skin erupts, you're going to see a really bad looking wound. But if anybody, any caregiver says everything looked fine yesterday and now it erupted into this, yesterday it looked like this and somebody should have noticed it. So it's something I kind of keep an eye on. And I thought I'd bring to your attention because I'm hearing some ombudsman talk about this a bit more. Whenever we're evaluating a pressure sore, it has to be in the context of this person's situation. Not for 1 minute do I think every pressure sore is a sign of abuse or neglect. There are pressure sores that can happen despite great care or even just despite adequate care. But you need to know what else is going on. What is the functional status of this person? Have there been regular skin checks? What does the documentation look like? People sometimes send me just a photo, a close-up photo of a pressure sore and ask if it was abuse or neglect. I have no idea. I need all the contextual information. So it's really important for those of us working in the field to try and gather that information. Is there a chart where you can see if there was awareness, a team-based approach? Hey, look, this person scores high on an index that says they're at high risk of skin breakdown. Here are all the things we've done. Here are the team meetings we've had. Whatever it might be, some awareness that it doesn't just sort of pop out of nowhere. And of course, do we know what the goals of care are? And so all of these things are helpful when we're evaluating a pressure sore. And before I move on to bruises, Nicole, are there any questions or comments that I'm getting in the chat related to what I'm blahing about?
No, you're doing a great job and a lot of support from your fellow long-term care ombudsman here for you.
All right, go Ombies.
There is a question, a clarification on the last photo. Was that the heel or was that a different part of the body?
Yeah, that's the heel. That was the heel. I'm not going to go back just because in case anybody's not wanting to see it, but that was the heel. Unless you want me to go back and talk about it more.
No, that was just a question from Emmy. And also just a reminder to everyone, feel free to drop your questions in the chat or the Q&A because Dr. Mosqueda is going to be stopping throughout our presentation.
Thank you very much.
So no, feel free to go on.
Okay. All right. So now I'm going to turn and talk a little bit about bruising in older adults. And this is just real quick, a study that we did. And this came about many moons ago because I was just trying to really learn a lot about elder abuse. And I started riding along with Orange County Adult Protective Service folks because I was working at UC Irvine at the time. And then I started riding around with police because I would see an older adult who was super bruised and everybody would go, oh, you can't tell anything. They're just old, they bruise easily. So we decided to do this study looking at bruising in older adults. And I know it sounds easy, but we had to find 100 older adults where we had good evidence that there was no abuse and say, can I come to your house every day at about the same time, plus or minus an hour, get you buck naked and look for bruising? And so, you know, they weren't like breaking down the doors for this study, but we got it done thanks to a wonderful team. And what we looked at were about 100 older adults where there was no evidence of abuse, looked at their bruising. And then we looked at about 70 older adults where there had been real evidence of abuse and looked at the differences between the bruising. And what we found, and I'll show you some not photos, but some picture graphics in a minute that'll make it easier, is that inflicted bruises due to abuse were more likely kind of on the head and the torso or on the buttocks. They tended to be on multiple planes, meaning that it wasn't just on your chest, but if it was on your chest and on the side, so different planes of your body. They tended to be bigger and took longer to resolve. It also turns out that we're really lousy when we see somebody with bruising to say, hey, how did that bruise occur? We meaning physicians. And I'm really encouraging physicians to just ask the question and be open to the fact that it might have been due to abuse. So here's a picture that we call the anterior view. So this is with standing with palms out. And what you'll see is a lot more bruising on the head, in upper arms and chest. And now I'm going to show you the posterior view. A lot more bruising here, again, head, torso, and buttocks. So if I see a bruise on the head, does it mean that person was abused? Don't know, but it sure increases my index of suspicion. So we're really pleased that folks in the emergency room, for example, are using this. I was really happy a few years ago when I was taking my board exams, and there was this question about my research study on the board exam, which I think I got right. So, you know, good all around. All right, so that's a little bit about bruising. And what I'm going to do is show you pictures of bruises. They're not, you know, I just wanted to warn people, because what I'd like for you to do is think about whether or not, and maybe just a few of you could put it in the chat, do you think a bruise here, is that concerning to you? Do you think, oh my gosh, something bad happened or occurred here? Yeah, right. It doesn't look that bad. I'm with all of you. Like, that's an easy place to bump yourself. All right, exactly right. Now let's go to this bruise, which is on the inside of the, just below the elbow. Yeah, possible, right? This one, I'm going to be, it's a weird place to bump yourself, but it could happen. It could be a grit bruise, absolutely. I'm going to ask a question, how did that happen? And see if their answer makes sense. All right, what about this bruise? Yeah, everybody's worried about this one. It's gigantic, it's on multiple planes, it's highly suspicious, and it turns out it was due to a benign cause. This was a patient of mine who knew I was doing a bruising study and very proudly came in to show me her massive bruise that occurred because she has some gait imbalance, was stepping over into a bathtub, and she knew she was going to fall. And she said, I had to slide down the bathtub. And she said it was painful and unpleasant, and I knew it was going to look bad. And she also, at that time, was on a medicine called Coumadin, which we don't use that much anymore. She gave a story that fit the bruising pattern that I saw. I still asked her, has anybody hurt you? And she said, hell no. If anybody hit me, I would hit them right back. So I said, okay, I'm going to believe you on this one. But yeah, this is a really scary looking bruise. And finally, I'll show you this bruising picture. What do you all think about this one? Are you worried? And I'll tell you the story too, which is this is a man with dementia, and his sons brought him in saying that he fell. Yeah, we're worried about this, man. It isn't up high enough, but there's also some bruising on the neck. Bruising on the neck is always a big blinking red flag. But yeah, weird location, big bruising all over the place. How do you fall and get bruised here, here, here? And it did turn out that this son had been beating him. We'll talk, I'm not going to show you the data on this, but we have to be, I learned that you have to be really careful. It's very hard to date a bruise by its color. So I'm always very cautious with age of bruising. There's some general things we can say, but it's really hard to say how many days old a bruise is by looking at its color. So yes, very, very suspicious for sure. I'm going to show you another study done by colleagues at Cornell while Tony Rosen and his group. And what they did was really interesting. They looked at injuries of people who were proven in court to have been physically abused. So like pretty much no doubt that abuse really occurred. And then he looked at injuries of people who came into the emergency room who had an unintentional fall and looked at their comparisons. And here's what he found, that 1 in 5 people who had been physically abused had no visible injuries. But if you ask them about pain, tenderness on exam, they had pain, usually on the torso or in the face or neck. So one thing we're doing is teaching physicians, nurses, everybody in primary care, nurse practitioners, PAs, to check and document when people have areas of tenderness. Because one of the things that drives folks nuts, I think especially some of the wonderful police and prosecutors we have out there, is the terrible job of documentation that I and my colleagues do, where we don't make a note of where an injury is or what it looks like and whether or not it was tender. We've developed a form that healthcare providers can use for that now. But so this was the study. 1 in 5 people who were physically abused had no visible injury, but here's a picture of what they found, and the size indicates the number of people who had injuries in these areas. So more on the left side of the face, theoretically, because people are right-handed and it goes kind of across the body. Neck injuries, if you see a neck injury, it was 6 times more likely to be due to abuse rather than a fall. Ear injuries only occurred in abuse and not in falls. So we're beginning to gather some information like, you know what? Okay, we got all those normal, common age-related changes of aging, but we can begin to start to tell when things are a little more suspicious and deserve a closer look. So a few additional markers. Let me pause actually right there before I move on to other markers and ask you folks to let me know if you have any questions or comments on the info I've just shown you.
We have a question here, and I think it relates to the bruises you were showing. Mm-hmm. And so is it possible to look at sort of like that, because some of the color was changing over different periods of time? Yeah. Is that an indication of repeated abuse over time, or just that's the way the body goes?
Yeah, not necessarily, because it depends on like the depth of injury, what other medications you're on, and the mechanism of injury, how hard you were hit. Because one can imagine in a fall, like there might be the initial impact and that area got hit harder than another. So it's really hard to distinguish that. There is kind of a sequence of colors that most bruises go through. But like in our study, we found that some bruises remain red for 3 weeks. And we used very sophisticated technology. We used paint chips to make sure that we were checking the colors and monitoring them, and we categorize them every day. So it's pretty hard to date the age of a bruise and compare ages of bruises even in the same person.
Okay. This may be something you want to answer later, I don't know, but what advice do you have for family members who are advocating for loved ones in a long-term care setting as it relates to the potential abuse or concerns about that?
I would love to answer that later. It's a really important question. And so if you can help me remember to come back to that, I'd love to, after we put it in the rest of the context of this talk. So I'm gonna move on now, and feel free. I really appreciate you continue to ask questions and make comments, and just spend a minute talking about medication misuse. Sometimes we think about elder abuse and we don't think about how medications can be used as a form of elder abuse. And it can either be you given too much or too little. So, and it can even be with the same thing. So I've seen people who are on pain medication who were given excess doses to put them into a state of delirium so they would sign over checks for financial abuse. So that's overdosing. I've seen people who were on pain medication who were given too little, or it was being withheld with a threat. If you don't sign this check, you're not getting your morphine. Or, if you don't sign over your house or your car or whatever, or you're bothering me too much, I'm not, you have to go to the bathroom again, I'm not even going to give you. So it's used in a whole variety of ways. And the other thing is sometimes we're up in the dose of, say, a thyroid medication, or somebody's supposed to be getting insulin and their blood sugars are way out of control. And what we often do is, as physicians, as healthcare providers, is like, oh, I'll just increase the dose of medicine they're on. We got to remember, they might not be getting the medicine. So it might be out of control because they're not getting it. Or I'm doing labs and this person has a feeding tube in, and there should be no reason why they're not getting certain medications, but they're clearly not being given because you have a blood level of 0. So we can use medication levels both directly and indirectly to look at this sort of stuff. I think this was all I was going to say about medication, so I'll just pause real quick if there's any questions or comments on medication stuff.
We just have a comment here of that oftentimes folks will see a relative or caregiver taking the older adults medication, using it for themselves.
Yes, that does happen. And so, sometimes somebody's on hospice, you keep going up on their dose of morphine and you check their blood level and it's 0. Where's that medication going? Could be an example. So yes, that absolutely happens. And it needs to be thought of and addressed for sure. All right. So I also see a question about monitoring correct doses. It really depends on the medication. Some medications you actually directly can measure the amount that's in the bloodstream. There are other things that are indirect. So if somebody's on thyroid medicine, for example, you're measuring a hormone that responds, that it's sort of the opposite of what you'd think. The level should go down if the thyroid dose is going up and getting administered correctly. So it really depends on what the medication, in terms of whether you can monitor it and how you can monitor it. Okay, should I move on now, I think? And Nicole, you can help if more questions come up towards the end that I'm missing right now. So other indicators of possible neglect, somebody's malnourished. So again, you got a feeding tube. Hopefully we'll be seeing less and less feeding tubes, but somebody should not be malnourished if that's going on, or their tray is just being left at the side of their bed. Are they getting fed every day? Kind of, but if they can't open their tray or open that juice container or whatever, they may end up getting dehydrated. People who are coated with fecal matter or urine stained, inadequate clothing. And I almost always take off shoes and socks, because sometimes people will kind of get somebody looking okay to come into the doctor's office, or if they know I'm going to be there, but they never think we're going to look at the feet. And then of course we look at pressure sores. Okay. So what I'm going to talk about now is what the heck do you do with all this? Because it can really, at least for me, feel kind of overwhelming and confusing when I'm trying to sort through all these things. We've got these injuries, we've got labs, we've got context, we've got family members saying different things. How do you figure all this out? So I like to consider a whole variety of things. What are this person's vulnerabilities? Do they have a dementia? Are they able to give me reliable information? By the way, you can't make a blanket statement. Well, they've got Alzheimer's. You can't believe anything they say. Not true. There are things that you can believe. So I think we owe everybody the respect and dignity to listen to what they're saying carefully, not dismiss it, look into it, and get a sense of what's going on. I want to know what this person's functional status is like. Do the explanations make sense? Why does this person have a bruise on their foot? And somebody says, well, they fell. Like, it's hard to get a bruise on your foot. And if you're non-ambulatory, it's even harder. So what's going on? So do all these things fit together and make sense? As we hammered away a minute ago, whenever I see injuries to the head, face, neck, I'm particularly concerned. Pressure sores can happen, but why did anybody wait until it was a smelly stage 4 to call anybody's attention to it? For people with dementia, I look at things like sudden changes in behavior, which can occur with dementia, but for me, it's a medical problem until proven otherwise. One of the things on my differential is abuse. So these are the kinds of things I consider. Now, this is I'm going to show you a model in a minute called AIM, or the Abuse Intervention Prevention Model, and hopefully some of you can relate to this. Have you ever had a really messy desk and you've got papers kind of all over the place, and you just like don't know what to do with all of it, and then you start separating the papers into piles, and so that they kind of logically go together, and you put them in neat stacks, and then even though it's the same papers on your desk, you feel better about it? Somebody please tell me that this happens to them too. That's where I came from when we were creating AIM. It was sort of a way to take a lot of messy information and put it into 3 neat stacks. And the neat stacks on this framework are: what are the characteristics of the older adult who might be getting abused or neglected? What are the characteristics of the trusted other who might be doing the abuse? And what is the context of their situation? I'm so glad some of you can relate to this. So we separated into these 3 domains: the older adult, the trusted other, the context, and then we look at what might be going on. Does the older adult have dementia? Do they need help with ADLs? Does a trusted other suffering from depression? Are they very dependent on the older adult? Otherwise, they wouldn't have a place to live. We look at the context of their situation. What are their relationships like? Does the whole family get along? Do they not get along? Is there some degree of social integration? So they're going to a PACE program, or they're getting out, there are available resources in the community. What are the cultural considerations that we need to take into account for this particular person? There are some cultures where the worst thing you can do is yell at an older adult. There are some cultures where the worst thing you can do is ignore an older adult and not talk to them at all. So understanding all of those things are really important. And what I find is that if you sort of put them into these buckets, you can start to see, well, we can do something about this. I can't change the culture, but I can help treat this person's depression. So what I'm going to do is sort of roll through a case example. And what I'm going to ask you all to do is think about, as you're hearing the case, what are the risk factors in the older adult? What are the risk factors in the trusted other? And what are the risk factors in the context of the situation? So we can just apply the model straight away here. So here's the story. Mr. and Mrs. S. He has Alzheimer's disease, and she brings him to the doctor's office. He's 86. It's moderately advanced, and he needs help. He needs help with dressing because, for example, he puts his right arm in the left sleeve and just kind of gets confused. So she needs to help with these things. He doesn't really like other people helping. He kind of resistant to care, so that when she offers to help, he might just push her away a little bit. The last time he was in was 6 months ago, and he's had a pretty big decline in his cognition since the primary care provider saw him 6 months ago. He's unclean, his clothes smell of urine. And so we do what all good primary care providers do. We call for help from social workers and say, hey, I'm kind of worried about what's going on here. Can you look into it? And the social worker, finds out that yes, Mrs. is his primary caregiver. She has pretty severe osteoarthritis, which makes it in a lot of pain with it, which makes it harder for her to assist him. And she doesn't really know what to do when he resists care. Like she says, I know he smells like urine, but he wouldn't let me change him. And she's feeling nervous all the time. She can't sleep well. I'm still going on with the story. Hopefully you guys are taking notes about which domains these fit into. So she's feeling nervous. She can't sleep well. They've been married for 30 years. They've never had any children. But remember, he was 56 when they got married. He had a prior marriage and he had 3 kids. They never liked her. Those 3 kids, even though they're adult kids, never liked Mrs. S. And that's made it pretty difficult for her. They're financially secure, but she's never handled the finances. Their whole marriage, kind of a cohort effect, he's been the one handling the finances. And now she's worried whatever decision she makes, those kids are going to be critical of these decisions. And she just now feels overwhelmed. She has stopped playing bridge, going to the movies with friends, feeling kind of isolated because she just you know, full-time, feels like she needs to be at home taking care of her husband. So this should be a story that's fairly familiar to a lot of us. And what I'd like for you to do now is, let's start with the blue box here. What are some of the risk factors you see that might make Mr. S more susceptible to abuse or neglect? Just a couple things. All right. Too much for her to handle, dementia, the Alzheimer's, right? Got it. And what are you're great. And you're also talking about some of the other categories too. So for him, it's like the dementia, resistance to care, his physical needs. What about in her? What are you seeing in the trusted other that make you say, oh, she's kind of at risk for being abusive or neglectful? Social isolation, lack of support, not sleeping, right? Overwhelmed. Bang, you guys got it. You're so awesome. Okay, now what about the context? What are some of the contextual factors that you're seeing? Maybe some of the isolation. Yeah, kids don't like her, lack of strong family support. You're nailing it. This is great. So here are some of the things that I would fill in the boxes with. Now, I can't take away his dementia, but this begins to say, well, maybe we can do something to help with handling ADLs. Maybe there's equipment that could help. Maybe there's a caregiver that could come in. Maybe we could help Mrs. S get some treatment for depression and anxiety. Maybe we can help get her osteoarthritis better treated so she doesn't hurt so much. You know, I don't pretend that you can fix family relationships that have been going on for so long, but could there be at least some counseling that would help them communicate with each other? So by putting it into these boxes using this AIM model, it just begins, it's just sort of an organizing way to say, I can do something about this. It gives you like a few things to do. And my analogy is, for those of us who do healthcare for older adults, we know that we do fall assessments for people who are on what I call the frequent faller program, even though they don't get mileage. It usually isn't one thing we do that prevents them from having more falls. It's getting them hearing aids, adjusting the glasses, treating the depression, getting them off that medication, getting them some physical therapy. So it's usually like 6 different things we do, and combined, they decrease this person's risk for falling. I find the same thing to be true with elder abuse. You can do a little bit of this, a little bit of that, several different things. And when you do them all together, it decreases somebody's risk of abusing or neglecting or becoming abused or neglected. So hopefully that model makes sense to you all. Any questions or comments about this model? Yeah, home health could prove very beneficial for these folks. Great. Yeah, I hope somebody said it helps to clarify things more easily, which is exactly our intent. It's so interesting because we use it in our research too for kind of different purposes, but I just sort of carry it around in my brain now and use it in my clinical practice. Yeah, feel free to go forth and use it if you find it helpful, and modify it as you wish. Just so you know, it's 12:40 right now. I'm going to definitely finish by 12:55. And the remaining slides are going to be about resources, so we really will have time for some Q&A and conversation. And I know Nicole is going to want to wrap it up as well. So I'm going to just plow ahead because we're almost done, and then we can go into more of a conversation mode. All right, so again, you'll have all the slides available, but we have the National Center on Elder Abuse. I hope you're on our newsletter. If not, sign up. And don't forget, June 15th, World Elder Abuse Awareness Day. There's going to be a lot of stuff rolling out related to that. But we have a lot of really practical information on our website, so we hope that you'll use that. These are some of the things we have about reporting. I don't need to go over this with you because I know you know it, but I wanted you to be aware that these are resources that you can download, print out, and use, so you don't have to reinvent the wheel. We have these fact sheets, brochures. We have this initiative called STEEP, this initiative that allows you then to put your own brand on things. Just take it and make it your own, and use it, so you can use it in your local communities. We have a separate website that's linked through the National Center called TRIA, the training resource. So if you want to give a talk on elder abuse to either professionals or lay or whatever, you have vetted information on here that's all available for free to take and use. It's videos, it's slide presentations, mix them and match them, trade them with your friends, and please avail yourself of the resources we have there. Our resources are available in 8 languages, we're very proud to say. This is the STEEP that I was telling you about, support and tools for EA prevention, with fact sheets and outreach ideas. And again, you can pop your own logo on there so that people really know it's from you, from your organization. And we have a toolkit that's very customizable, so you can really use it for your own needs. All right, some stuff specific to nursing homes, and we do a lot of work with Consumer Voice and of course the National Ombudsman Resource Center. It's everything from FAQs to how the long-term care ombudsman program works. All right, so we're bringing it home now. This is a slide to remind me to tell you that all older adults are not the same, and that in fact, really one of the hallmarks of aging is heterogeneity. The older we get, the more different we become. So we can't treat older adults as sort of this monolith. You know, I can show you 90-year-olds who are playing tennis twice a week, or more likely pickleball, or getting out and about with friends, really enjoying life. 90-year-olds who have advanced dementia, or and everything in between. So we don't want to treat older adults as a monolith. Everybody deserves the respect to get treated as an individual in the context of their own lives, their own purpose, their own meaning, their own context and situation. No matter how old we are, we all need meaning and comfort, identity, joy, inclusion, and lots of love. I think, these times during COVID have been incredibly difficult. I was on the phone with some higher ups earlier today, pushing for easier access for family members to get into nursing homes, that they shouldn't be limited because we're limited with our testing, but that older adults deserve to be empowered to decide whether they want to take the chance of a loved one visiting them, because we all need those connections. And I just really want to end by thanking you. The folks on this webinar, you're the ones who really make a difference. And I just admire so much the work that you all do. I saw the mix of people from APS and Ombudsman and social services. Thank you. Thank you for what you do. Prosecutors. It takes all of us really to do this on behalf of a vulnerable population. And then we don't want to forget that we need to include that vulnerable population in all we do, so that we hear their voices. So let me pause right there. And I think this gives us about 10 minutes for Q&A, and then 5 minutes for Nicole to wrap up. If I have that right, I'll turn it over to Nicole so that we can sort of have at it here.
Thank you, Dr. Mosqueda. That was wonderful. And you had some lovely comments in the chat. Many folks wanting to say hello to you, and I remember working with you over many years.
That's great. How wonderful.
So I'm wondering if you can pick back up with the question we had earlier around the advice for family members who are advocating for loved ones who live in a care facility and how they can be advocating appropriately, particularly if they have concerns around potential abuse.
Yeah, and I would also refer you to Consumer Voice, where they have some really good materials on this as well. I think you need to be there, you need to be present, you need to make yourselves known. I think it makes a difference when in nursing homes, when they know that you're there and watching them and that you're engaged. I hear it and I see it, that folks are just a little more aware that somebody is really looking after this person. If you have a suspicion of abuse or neglect, you got to call the Ombudsman, the long-term care Ombudsman for that facility. If you think there's immediate jeopardy, get law enforcement for sure. I would say that rarely happens, and oftentimes folks in law enforcement aren't really sure how to handle nursing homes. We have a pretty mishigas system when it comes to figuring out what's going on in nursing homes when there are concerns about abuse or neglect. So that's why I recommend generally starting with the Ombudsman, who then can get in there, advocate, know who to talk to. And family members oftentimes, even though it's posted or it should be posted, often aren't aware that Ombudsman exists and what their role is. And Nicole, I would invite you if you have anything to add, if you think I missed something there.
Oh gosh, yes. Always love you putting in a plug for Ombudsman. If you're not sure of who your local Ombudsman program is, just Google long-term care Ombudsman and your county, or you can call your local area agency on aging and you'll be routed to them appropriately. You do have local representatives, and I want to remind everyone, Ombudsman have been back in facilities since fall of 2020. So even if you as a family member aren't able to enter due to testing restrictions, the Ombudsman certainly are. And that is a great way to start sort of a care community, a care plan, folks who can support you. So thank you, Dr. Mosqueda, appreciate that. Here we have someone saying something really important is one of the issues they're seeing is the lack of coordination among medical practitioners around care for older adults. How should that be handled? And how can we prevent things from falling between the cracks or between the practitioner?
Yeah, it's a huge issue. We see it all the time. I was very fortunate when I started doing my elder abuse work. I was in Orange County, where they have just this fantastic APS agency. If there's anybody from Orange County, hi, you guys are wonderful. And I just loved working with the APS workers there who taught me so much. And one of the things I really learned at that stage of my work was this lack of coordination, lack of communication. And I think it's a big issue when it comes to abuse and neglect. What we can do are try and push through, people often claim HIPAA. We can't tell you anything because of HIPAA. And oftentimes it's I was about to use a bad word, BS, we'll just say. And I think, we need to tell physicians loud and clear, no, you are not only allowed, you are required to provide me that information. And so really knowing what the laws and regulations are so that you can push back when people are hesitant to provide information, I think is important. The other thing is, and this is something that I'm talking to some folks at the federal level about, is we don't have systems or electronic health records that allow for communication. So when somebody leaves the hospital and goes to a nursing home, you have to hope that all the records get transferred. They can't just go into an electronic health system and see it. And furthermore, a lot of nursing homes are in these bizarre hybrid models of some things on paper and some things in the electronic system, which makes it really hard, I think, as an ombudsman to figure out what the heck is going on, and can be used for bad purposes and to hide stuff too. I don't think I'm answering the question, am I, Nicole?
No, I think you're clearly articulating what some of the barriers are that we all need to be aware of to advocate for change.
Yes, advocate for change. And also, when somebody says, oh, we can't get that information, then the answer is not okay. It's like, oh, well, you can, let's just figure out how to do it. Let's not say we can't do it. Mm-hmm. Let's just say we're not doing it and we need to figure out how, because it's really important for us to see this in order to understand the context of how acts occurred. So I think it's fine to get a bit pushy.
Yeah, thank you. You know, sometimes I find that physicians or medical professionals, they're wary to report because they like the family or they feel like, no, I don't think it's really happening. And reminding them that they don't have to do the investigation. It's just their duty to report that reasonable suspicion.
Yeah, I really learned that from my colleagues in pediatrics. Before we set up an elder abuse forensic center in Orange County, I spent a lot of time with some pediatricians in San Diego who were doing a lot of work in child abuse. And they just really put this into my brain. It's a reasonable suspicion. It's not your job. And so we're trying to communicate that to healthcare providers. I just recently did a grand rounds for a group of internists at UCLA. And I tell them, it's not your job to make a diagnosis, although if you can, please do. It's your job to have a reasonable suspicion and hand it over.
Great.
One other comment, and I'm sorry, I just have to say this and I mean no offense by this, but we also have to figure out a way to get back to the providers who are making a report. And because what I hear over and over again from healthcare providers is like a black hole. I make a report to APS and I never hear back. I don't know what's going on. We really need to figure out some way to make it okay to provide information back.
Very true. And maybe allow for that to be reimbursable, a code to have it be their time be reimbursed when they're making that report or hearing that report back. So there's an incentive to do that. So I'm wondering, you know, what if someone has some hallucinations, like that's part of their dementia they're experiencing or the medication is causing it. So how do you deal with someone like that, particularly when they are making repeated allegations of abuse?
Yeah. And I'm going to talk about two types of psychosis. One is hallucinations and one is delusions. Just a reminder, so hallucinations are when you like see something that isn't really there. That's a visual hallucination. Or an auditory hallucination is you hear something that isn't really there. And then delusions are fixed false beliefs. So a delusion is when you believe something is happening that's not really happening. So somebody stole my pen. It's my favorite pen and somebody stole it. And and really what happened is the person has Alzheimer's, they put it down, they think they put it down somewhere, they can't remember. It's not where they expected it to be. I don't have a problem, my memory's fine, somebody stole my pen. Or it can then start going into paranoid delusions. So I have some families where I have older adults making allegations of abuse or neglect. They're delusional. And I've documented. We've looked enough to say, that that's not happening. I don't have a reasonable suspicion. I haven't made a report, and I document it on their chart. The older adult is saying that X is happening. I see no evidence of this. I have no reasonable suspicion, so I'm not making a report. But it gets documented in case, God forbid, I'm wrong. Or what's even better is if we're not sure and we do make a report because we have a reasonable suspicion, that there's a way to write on the forms, please call me before you go out so I can explain the situation, because I think it makes it a lot easier if the police officer or ombudsman or APS worker knows that this is going on ahead of time. And this gets back to, we need improved communication.
Thank you. I think we have time for like one more question. This is a really good one related to COVID, which is oftentimes we are not with our clients, particularly now with Omicron. So, but if you suspect elder abuse, do you have any techniques that can be used to talk to that person via the phone or the iPad or whatever, that you can broach that conversation and yet still keep them safe when you don't know who's on the other side of that monitor?
Yeah, so what I like to do is, so if I'm just going to assume, to not make it even more complicated, I'm going to assume this is somebody who knows how to use the monitor and stuff. And I say, it really helps me to see your house. So can you show me like what everything looks like? Or I'd love to see your little dog, or whatever it might be, so that we have some really good excuse that at least allows me to see if in the room there's somebody who's just running out the door. And that's kind of the best I can do. And then I can just say, hey, is anybody there with you? It just helps for me to know who all's there, and keep it in a very casual, non-confrontational, judgmental, accusatory tone.
Mhm.
And that's really the best you can do to make sure that nobody is there. And then if I'm concerned, I would ask sort of general questions that don't necessarily make them implicate somebody or name a name. But say, there's so many things we can do to help. If you're feeling really isolated and sometimes you're worried about your own health and safety, there's a variety of things we can do. And maybe we can, set up another time to talk that's convenient for you. So you can, I think, talk around it a little bit vaguely enough so that people get the idea, then you get the idea.
Yeah. That is tremendous advice. Thank you. We definitely use that in our practice. Want to give you a few moments to close out before we talk about next month's session.
Wow. Well, I think it's what I said before. I really am so grateful to everybody who's attending this. I mean, and to you, Nicole, and your group for hosting these things so that we have an opportunity to talk about it together. I always learn a lot from your questions and your comments, and I just remain grateful. I know that most of you are in positions where the people you're helping never are able to express their thanks. So I would like to express thanks to you because you're doing a lot of good in the world. You're making the world a better place, and we need more folks like you.
I could not have said it better. Thank you so much, Dr. Mosqueda. We appreciate you being here with us. As a reminder, we will be sending out the slides along with the recording next Tuesday to everyone who is registered. I want to say we're going to drop the registration link for next month's session in the chat shortly. It is going to be a really interesting and I think insightful personal conversation. We're going to hear directly from Shirley Crone. She is a member of the California Senior Legislature, former president of the Local Advisory Council on Aging, and all-around expert and advocate for older adults. And she is going to tell the real story about how easy it is to get taken in by an online scam. And I think so many of us work directly with clients and say, how can we keep them safe? Well, you're going to hear from someone who's an expert, and they're going to talk about their own recent experiences related to online scams. So Shirley's a friend of mine and the organization's, and she'll be here with us. So I want to encourage everyone to click that link and register for next month. Wishing everyone to stay healthy and safe, and we will see you back here shortly. Thank you so much.